on Dr. Yiumo Michael Chan, AnnJi Pharmaceuticals from Taiwan, to deliver his keynote presentation. Yiumo Michael Chan's research in areas include rare disease research and drug development of small molecules. He received his Bachelor of Science and PhD degrees from the University of Chicago and completed his postdoctoral training at Harvard Medical School. He has extensive research and experience in academia and held a faculty position at Geisinger Medical Center, Pennsylvania. He is a scientific leader in rare and neuromuscular diseases with a proven record in publication and discovery, including the identification of the genetic basis Weber-Cochrane epidermolysis bullosa simplex. He also serves several scientific advisory boards for different patient organizations of rare diseases. In industry, he demonstrated a successful track record in drug development of small molecules. He was responsible for the translation program in neuromuscular and neurodevelopmental diseases at Ultragenyx, California, including the GNE myopathy program, which advanced from clinical stage to phase 3 clinical trial. He's currently the Vice President of Research Translation Medicine at AnnJi Pharmaceuticals, a clinical stage biopharmaceutical company specializing in the development of novel treatments for neglected diseases in neurology and dermatology. He has led more than 6 phase 1 and 2 clinical studies for common and rare skin diseases. Please welcome Dr. Yiumo Michael Chan.
Yes, thank you very much here. So thank you, the organizer here. Should I pull my slide and use the share screen? Hello? Hello, can you hear me? Hello? Can the organizer hear me?
Yes, doctor, you can share your screen now.
Hello? Hello, can you hear me? Hello, can the audience hear me? Or can the organizer hear me? Okay, I think the audience can hear me, and thank you very much, for the organizer and for the audience, to take part in this wonderful conference here. So today, actually, the title of my talk is Androgen Receptor, Oxidative Stress, and Inflammation at the Crossroads of Skin Disease. Next slide here. My disclosure here, I don't have any conflict of interest here, and all the data are either published and publicly available here. I do serve in a number of scientific and medical advisory board in the US. I just want to make sure again, can you see the slide, number 3? And can Dr. Francis, type of response, to make sure actually the audience can actually can read my slides. Yeah. Yes, I presume actually the audience can read my slides and hear me. Actually, today the objective actually. Okay, got it. Very good. Thank you. Thank you, Dr. Francis here. So the objectives of this presentation is we have 4 parts here. So the first part here, trying to demonstrate actually androgen receptor is a very promising druggable target here. And then I would describe, a novel class of the compounds that developed, by our company, to target androgen receptor signal pathway here. And we'll go over actually recently completed clinical study using a topical formulation of that compound for the treatment of acne in a global phase 2 study here. And then finally, I will highlight the potential of targeting androgen receptor or androgen receptor signaling in other skin disease. So I think just the first part is a brief introduction of androgen receptor here. I believe that most of the audience and probably have a very good knowledge of the androgen receptor and its important role in skin or skin disease here. So basically, the androgen receptor is a ligand-dependent transcription factor to regulate gene expression through androgen responsive element and other factors here. So the ligand including testosterone or other more potent form of the androgen, such as DHT here. So basically, androgen together with the androgen together with the androgen receptor, it plays a critical role in many cellular processes, from hair growth to muscle growth here. And typically, upon ligand binding, the androgen receptor will dimerize and then translocated from the cytosol to the nucleus, and then to activate transcription of many genes together with other cofactors here. So historically, androgen receptor has been extensively studied as a drug target in prostate cancer here because dysfunctioning in androgen receptor here is thought to play a pathological role in prostate cancer, from overexpression of the androgen receptor protein to the mutation in androgen receptor gene, and from the change of transcription activity from differentiation to proliferation here. So they are all tightly associated with the function of androgen receptor here. And currently, there are a number of the treatments, mostly to target either androgen deprivation therapy to reduce the level of the androgen, such as testosterone, from castration or to other small molecule to reduce the level of the androgen here, to androgen to a class of the compound called the androgen receptor antagonist here, or the anti-androgen here. The purpose is actually to basically block or reduce the normal androgen binding to the androgen receptor here. So this is a very simple schematic diagram of the androgen receptor protein here. So the protein, a very extensive study over the decades here, it consists of different functional domains here. One of the most important is the C-terminal, the ligand binding domain, the LBD here. And this is where actually the ligand, the androgen, actually binds to it and then activate the androgen receptor into a dimer and translocation into a nucleus here. So far, most of the drugs approved in the market here are targeting the ligand binding domain here, either to prevent the androgen from binding to the ligand binding domain, or to prevent the dimerization of the androgen receptor here. There are a number of drugs actually from different companies or from academia here, and trying to target different functional domain in the androgen receptors here, from the very end terminal transcription activation function domain to a DNA binding domain here, and those are all under current development here. So in summary here, androgen receptor is a proven druggable target in the drug development world here, in particular to modulate the androgen receptor signaling pathway here, either through the androgen deprivation therapy or the anti-androgen therapy here, at least in the prostate cancer here. And the question actually we want to ask, in the next section is, are there other alternative way actually to target the androgen receptor signaling pathway besides the two actually I mentioned here? So I would like to mention, although both the androgen deprivation and anti-androgen therapies might be clinically effective here, sometimes it does not address, all the clinical issues here. In particular, the androgen receptor protein quite often is still present actually, in the pathological state here. So in such case here, as you can see the diagram from the right-hand side here, there could be androgen independent pathway that without ligand activation here, the androgen can still function either negatively or positively. That depends on the pathological state here. So one way actually to target the androgen signaling pathway is actually to get rid of the androgen receptor protein by degrading or enhancing the degradation of AL protein. So that will proven to be a very good alternative to moderate the androgen receptor signaling pathway here. So here I would like to introduce, a compound called the ASC J9. This is a structural analog of curcumin. Yeah, curcumin is a very common ingredient, commonly found in food, in Asian here. So the structure is a highly symmetrical and very simple structure here. So, and using a transcriptional activation assay with a luciferase of reporter genes here, we try to screen for compounds that could actually reduce or block the transcription activity of AL here. So as you can see it, under DHT condition here, the transcription activation reached about 100% as the reference here. And without the DHT activation here, the transcription activity was about 50% here. And then we try to screen a number of compounds here and identify a compound called a J9, which is this structure here, can significantly suppress the DHT-induced androgen receptor activity here. And we compare with other known anti-androgen compounds such as HF here. Actually, it was much more effective, than other known anti-androgen here. So this compound actually, it turns out in the next slide here, it enhanced the degradation of the androgen receptor protein here. So as you can see in the prostate cancer cell line here, with or without the DHT ligand activation here, the J9 compound can reduce the level of the androgen receptor in the cell in a dose-dependent manner here. And the effect appear to be androgen receptor specific here because the treatment of J9 did not appear to affect other nuclear receptor proteins such as the estrogen receptor, retinoic receptor, or glucocorticoid receptor. As you can see it, their level actually remain more or less the same with or without treatment of the J9 here, in contrast to the androgen receptor protein here. So mechanistically here, we try to understand, the reason how it regulates the degradation of androgen receptor here, and we believe, partly has to do with the activation of the proteasome dependent pathway here. And in this figure here, treatment of the J9 here appear to activate the AK2 and the MDM2, which is a E3 ubiquitin ligase complex here, to increase the androgen receptor ubiquitination here. And because the androgen receptor is being degraded here, so it will functionally block the translocation of the AL to the nucleus here. So as you can see, first in the figure 1 here, treatment with the ACJ9 in the presence of the DHT here substantially increased the phosphorylation of the AK2 and the MDM2 in contrast to the as compared to just the DHT activation itself here. And it also increased the association of the MDM2 with the androgen receptor protein here, so they tightly form a complex here. And then as a result here, the translocation of the AL to the nucleus is blocked here. So with the DHT here, you can see the green signal, inside the nucleus, which is a debris from the vehicle here. Actually, it's kind of localized upon ligand activation here, but treatment with the ASC J9 here quickly, the androgen receptor disappear from the nucleus here. So in summary here, this is a proposed model of how J9 mediate AL degradation here. The first step is to increase the phosphorylation of the AK2 and the MMD2 here, and then to increase the activate the complex, and then increase the association with the androgen receptor protein, increasing the ubiquitination of the AL, then further promote the degradation via the ubiquitin proteasome pathway here. So as a result, the normal AL function through the dimerization and the translocation and activation of the gene expression here was functionally blocked here. So In addition, this compound also has some very interesting pharmacological activity, very similar to a class of compound called the NRF2 activator here. The NRF2 is a master regulator protein for oxidative stress here. Quite often, if a cell or if a system, is under oxidative stress or inflammation here, it will activate, increase, the protein level of the NRF2 to activate downstream antioxidant or anti-inflammatory genes response here. So in this figure here, we use a transcriptional activation assay to assess the stability of the NRF2 protein with or without with a number of NRF2 activator here. So this is the J9 here, and that's another analog called the JM17 here. Both compounds can increase the stability of the NRF2 protein in a dose-dependent manner here, and that's very similar to other known NRF2 activators such as DMF, dimethylfuran, and the RTA4A, which is oxalosolone compound. Yeah, I'm sorry if I pronounce it incorrectly here. So those are actually well-known NRF2 activators here. And on the other hand, you can also see it in a spinocyte or the macrophage system here, which was not shown here. The J9 can suppress a number of the pro-inflammatory cytokines here. When the cell was treated with R844, which is the riscosum here, which is a cell model for psoriasis, to induce Th17 immune response here. J9 or the JM17 here can significantly reduce the level of TNF alpha and the IL-17 cytokines in this cell line, in these cells here. So in summary here, the J9 compound here represent a novel class of a compound that enhance the degradation of the androgen receptor with antioxidant and anti-inflammatory properties here. We call it androgen receptor degradation enhanced ARDE here, or in the published literature here. So our next question is, with this pharmacological property in mind here, can we demonstrate this compound can be effective in treating androgen receptor associated skin disease in a clinical setting here, actually in a human here? So, and the disease we selected is acne, which is a very well-known skin disease associated with androgen here. So acne, without much introduction, is one of the most common skin disease, in the world here. It affects, mostly the sebaceous gland and affect people of all age and ethnic background here. And it's well known to associate with androgen here. For example, increase the sebum production due to the overactivity of the androgen and androgen receptor signal pathway here. So we developed a topical cream formulation of the J9 here to target androgen receptor for degradation, to modulate inflammation, and to activate antioxidant response here. The reason why actually they are important for acne is basically, the acne pathophysiology, thought to be four important parts of it. First, the excessive sebum production by the sebaceous gland here, and then the altered keratinization of the keratinocyte, with the hair follicle blocking the hair follicle. And then some of the infection, by the bacteria, and finally, chronic inflammation mediated by the cytokines here. So we believe the ASC J9 here can at least target two of the four major pathways, responsible for acne here. So this is just a very simple preclinical study here using a male fuzzy rat here to demonstrate J9 can effectively reduce the sebum production and the diameter of the sebaceous gland in the rat here. So you can see in the A here, when there's no treatment here, there's an increased production of the sebum here, which is tend to be yellow in color here, and then treatment with J9, a topical treatment with J9 here can significantly reduce the sebum production here. And we also measure the diameter of the sebaceous duct here, and treatment with the J9 here significantly reduce the diameter of the duct size. Now into the clinical study here. So this is a phase 2 randomized double-blind placebo-controlled study. We have two different doses here, 0.1% and 0.025%. And the enrolled population is 181 population, 181 patients with moderate to severe acne, and randomized into 3 different groups, 2 different concentration and 1 placebo here. The treatment length was 12 weeks, twice daily here. And there were altogether 7 sites, 6 sites in Taiwan and 1 site in the US here. And the major inclusion criteria is adolescent over 12 years old, both female and male here, and the facial acne with at least 20 to 60 inflammatory facial lesion, or 20 to 100, and also 20 to 100 non-inflammatory facial lesions here, and particularly with IGA, the investigator global assessment score of at least 3 and above here. And the key primary endpoints are the successful outcome in the IGA, defined as the score of a 0 or 1, with at least a 2-point reduction from the baseline at the end of the treatment, which is the week 12 here, and also a change of the baseline in the inflammatory, non-inflammatory, and the total acne lesion count. This is the demographic, of the cohort here. So the median age is 20 years old, and the majority of the patients are Asian descendants here. And most acne patients are moderate, 80%, and 20% are severe, defined by the baseline IGA score here. And the lower dose group here tend to have a little bit more male than the female here, whereas the high dose group here tend to have a more moderate acne compared to the low dose group here. I would like to share with you our efficacy result here. So primary endpoint of the IGA success, in every 2 weeks here, we check the IGA success number of the patients who achieved the IGA success here. So at the end of the treatment here, you can see clearly, actually both those achieved had a high percentage, of the patient achieved the IGA success compared to the placebo, which is the green one here. And actually, the lower dose, in fact, achieve a statistically significant, but not the higher dose. Although numerically, both appear to be superior than the placebo here. And in terms of the acne lesion counts here, in this graph here, we have the inflammatory lesion, non-inflammatory lesion, and the total lesion count here. So both dose, high dose and the low dose here, achieve statistically significant for the primary endpoint of the inflammatory lesion and the total lesion here, but we did not achieve the statistical significance in the non-inflammatory lesion, even though the trend actually appear to be to show actually, superior than the placebo here. And one interesting thing you can observe, we notice, in the clinical studies, both high dose and low dose here did not appear to show a very clear dose-response relationship here. They appear to be actually very similar. It's just a difference in the statistically, both in the lesion count and also at the IGA score here. And we believe, that has to do maybe perhaps, the saturation of the drug concentration, in the skin here. And this is just a quick summary, of the overall statistic, for all these primary and secondary endpoints here. And in particular, the low dose, the 0.025% here, we met 3 out of the 4 primary endpoints here, and we met also all the secondary endpoints in this clinical study here. And the safety summary here, basically, both those were safe and well tolerated in the patient here. So most of the patients complete the study here, and most of the AE are typically, very mild to moderate here, and no serious SAE was observed in the study here. And no systemic AE actually was assessed, related to the drug here. Because one of the reasons is because the drug has a very negligible systemic exposure here. Some of the, and this slide here, we compare actually our efficacy result with other approved products in the acne phase 3 pivotal study, in particular the testosterone, which is androgen receptor antagonist here, and Dapsone gel here. And you can see it in terms of the IGA success here, the testosterone and also the Dapsone actually, show a very comparable, IGA success with the J9 cream here. And for the changes from the baseline in the acne lesion count here, J9 was clearly superior than the Depson gel here and was comparable to the corticosteroid cream here. So overall, the efficacy result of the J9 here, even though the sample size was much smaller than the other pivotal study here, J9 show a very comparable efficacy, with other approved acne product in the market here. So finally, I would like to mention the potential of targeting androgen receptor in other skin disease here, because obviously there are many skin disease actually thought to be androgen dependent or involved with dysregulated androgen receptor signal here. And two of the examples, for the skin dermatology field is the heterogenetic alopecia here, in particular the male pattern baldness here, and also the hirsutisms in the females here, in particular associated with the polycystic ovary symptoms here. Another disease that actually been drawing attention here is called HS here, which has a very difficult way to pronounce the name, hidradenitis suppurativa here. This is a chronic immune disease here and involved with the hair follicle occlusion and inflammation here. In some way, it also has a name of acne inverse here, but it's a much more severe than the acne and has a much deeper involvement in the skin than the acne here. So it's extremely painful and embarrassing with recurring pumps here. And quite often, the treatment focus on the surgical removal, of all these lesions here. And the role of the androgen in the HS here is less clear than alopecia or hirsutism or acne here, mostly based on doctoral evidence here, because the disease is always associated with puberty, female menstrual cycles here, and off-label use of anti-androgen therapies here are quite effective, for females, HS patients here. In particular, the disease also has a very high comorbidity with acne or polycystic ovary cancer here, which are often dependent on androgen here. So some medications such as testosterone here may actually worsen the HS symptoms here. So collectively, we believe maybe at least a subset of the HS patient here could be susceptible to a localized response to androgen at the androgen receptor rich site in the skin here. So that would be actually a good target population, for treatment of for the J9 treatment here. And then finally, androgen receptor could be also a very attractive target in a neurodegenerative disease here. This is one of the disease, of the follicle disease, similar to Huntington disease here. The disease is called spinal and blood muscular atrophy, SBMA, or commonly referred to as Kennedy disease here. This is a very slow, progressive X-linked neuromuscular disorder here, resulting from a loss of lower motor neuron function from spinal cord and brainstem here. What is interesting is the genetic defect is the abnormal expansion of the trinucleotide CAG repeat in the androgen gene here. So this is a molecule expansion in the androgen receptor protein, resulting in the androgen receptor aggregation and gain of function toxicity from the aggregates here. So as a result, since J9 can actually enhance the degradation of the androgen receptor here, that could have a great potential to treat SBMA by degrading the mutant androgen receptor aggregates here. And in fact, in the preclinical study of the SBMA mouse model, J9 can actually improve the motor function in the mice and also reduce the level of the mutant androgen receptor aggregate here. So currently, there's all AnnJi is also conducting a phase 1 and 2 first in patient study of the of another J9 analog, we call it AJ201, to evaluate the safety, tolerability, pharmacokinetics, and pharmacodynamics in SBMA patients here. So finally, I would like to end by acknowledging my very wonderful co-workers at the AnnJi pharmaceutical companies here. Those are responsible for some of the preclinical study, some of the clinical operation and clinical study that I mentioned in this presentation here. And in particular, I would like to thank you, the PIs and the staff and the family, for participating in the clinical study for the acne here, and Xiaoping for the statistical analysis here. Thank you very much. Here, I think I'm just about